Okay, we're going to start on Module 16, Nursing Care of Patients with Cognition Disorders. Our learning outcomes, explain the cause, risk factors, and pathophysiology of schizophrenia, Alzheimer's disease, dementia, and delirium. Describe therapeutic measures used for patients with these diseases and plan nursing care for them as well. We're going to start with schizophrenia, and this begins on page 1368 in your book. It's now being viewed as a group of illnesses instead of a single illness. They may not be able to differentiate between what is theirs and what is everyone else's. They usually have poor self-esteem. Their attention span is short. It is a serious brain disorder of thought and association characterized by inability to distinguish between what is real and what is not. Schizophrenia is not the same as multiple personality disorder or dissociative identity disorder, as it's now called. There is an insidious onset and often begins during adolescence or young adulthood. It develops over time, and the symptoms may not be noticed for a short time. There are phases. We have the schizoid personality. Those that are in this phase are being seen as indifferent, cold, or aloof. They may be described as loners and don't seem to enjoy close relationships with others. In an adolescent, these things may be seen as normal teenage behavior, and not everyone in this phase will go on to develop schizophrenia. In the prodromal stage, affected people continue to be socially withdrawn and begin to show behavior that is peculiar or eccentric. Role functioning is impaired. Personal hygiene may suffer, and disturbances are evident in communication, ideation, and perceptions. Schizophrenia phase, this is a third and active phase of the disorder. Psychotic symptoms are prominent and include delusions, hallucinations, and impairment at work. Also, social relations will be impaired, and their self-care is impaired. During the residual phase, symptoms are similar to the prodromal phase. There is a flat affect and impairment of role functioning. The signs and symptoms are delineated as either positive or negative. Positive symptoms can be thought of as those symptoms that affect an excess or distortion of normal functioning. Included in the positive symptoms are delusions. These are fixed, false beliefs that cannot be changed by logic or factual proof. With hallucinations, these are false sensory perceptions, and they can involve all senses, but auditory and visual are the most common. A person might see a person that no one else sees or hears. I'm going to try to play these videos. I almost don't think it's going to let me, but let me try. Okay, obviously that's not going to work, so I will try to have those available to you if you're unable to pull them up when we review in class. Okay, now we'll look at illusions. These are mistaken perceptions of reality. A person may see a glowing sunset and think that the horizon is on fire. Those are the positive symptoms. And again, we'll look at those videos hopefully in class if you're unable to pull them up. Negative symptoms, think of these as a loss of normal functioning. These are thought to be the most debilitating symptoms since they prevent the person from living a normal life. A flat affect is a severe reduction in emotional expressiveness. People with depression and schizophrenia often show a flat affect. A person with schizophrenia may not show the signs of normal emotion. They perhaps may speak in a monotone voice, have diminished facial expressions, and appear extremely apathetic, like they just don't care and they have no emotion. Alogia is a term that means unable to speak. Avolition is a term that means no energy to do anything. Apathy is a lack of interest, enthusiasm, or concern. Anhedonia means unable to experience pleasure. And then social isolation, that's pretty self-explanatory. Some ideological theories. The psychoanalytic theory about schizophrenia is no longer believed, but it states that there's a failure to attain oral gratification, a lack of nurturing mother-child relationship. It is widely believed that schizophrenia is caused by a combination of neurobiological and environmental factors. Psychological factors are no longer considered valid because most researchers consider schizophrenia to be a brain disease. Neurobiological genetics is believed that the more genes are shared, the more likely it will be passed. Read about the identical and fraternal twin study in your book. The twin study is found on page 1368 at the bottom of the second column and goes into the next page. Other studies have found that schizophrenia clients have elevated dopamine levels in the brain, or the brain overreacts to dopamine, glutamate. Another excitatory neurotransmitter may also be linked. In summary, schizophrenia is believed to be caused by a combination of brain abnormalities and neurotransmitter dysfunction. Environmental causes may be central nervous system damage during childbirth, some infections, and substance abuse. And going to the psych unit with students in the past, there's been a diagnosis that I thought was pretty interesting called substance abuse-induced schizophrenia. And the times that I experienced that, seeing that diagnosis, it was cocaine that was the culprit. With schizophrenia, they usually experience unusual suspiciousness. They're paranoid, they're suspicious, and they're fearful at times with the paranoia. Unusual suspiciousness can be when they bring others into their delusion. They may bring nurses, family, TV personalities. They may show hostility, aggressive behavior, delusions of persecution or grandeur. And I'll show you the video if you are not able to read that or view that. They may say they're the next president of the United States, and they are not teasing. They truly believe that this could happen. With the hallucinations, auditory are the most common, and the auditory hallucinations may be followed by visual hallucinations. The voices may be frightening and derogatory, and they're responsible for some actions that the client may take. Schizophrenia clients experience fear, anxiety, suicidal ideations because of these voices. Another term we use when we are working with psych patients, attending to unseen others. This term is used for clients who speak or show motions as if there is someone there when there isn't. They may argue with the voices, thinking. One way we can kind of think about this is being in a room with 6 TVs on and different channels all at the same time, and how confusing that could be. Okay, on to therapeutic interventions with schizophrenia. Antipsychotic medications, if you'll turn to page 1359 in your book, you've got your typical and your atypical antipsychotics. And this table goes on for several pages. There are some side effects that go with both typical and atypical. The extrapyramidal side effects can occur with both of these. See the list of these side effects under the side effect portion. If you look at typical antipsychotics, we've got Thorazine, Haldol, Prolixin, Mellaril, Navane, Trilofan, and Stelazine. The extrapyramidal effects in that next column, pseudo-Parkinsonianism, that's when they look like they have Parkinson's, but it's drug-induced. We have akathisia, which is a state of agitation, distress, and restlessness that is an occasional side effect of antipsychotic and antidepressive drugs. Dystonia is a state of abnormal muscle tone resulting in muscular spasm and abnormal posture, typically due to neurological disease or a side effect of these drugs. One you might hear a lot about is tardive dyskinesia. This is a neurological disorder characterized by involuntary movements of the face and the jaw. And then one that's very life-threatening, although it's rare, is neuroleptic malignant syndrome. Again, life-threatening. This is an idiosyncratic reaction to neuroleptic medications. It's characterized by fever, muscular rigidity, altered mental status, and autonomic dysfunction. Atypical antipsychotic drugs that may cause this neuroleptic malignant syndrome include the following: olanzapine and risperidone. Back to the extrapyramidal side effects that can occur. We use anticholinergic meds like cogentin and Artane to combat these extrapyramidal side effects, or EPSE. Newer drugs like clozaril and Risperdal have fewer of these extrapyramidal side effects, but they have other effects. They also are helpful with both positive and negative symptoms of schizophrenia. I don't want to leave these drugs yet. You need to be familiar with these drugs. Our atypical antipsychotics, Safras, Clozaril, Latuda, which you probably heard of on TV, Risperdal, Zyprexa, Seroquel, Geodon, Abilify, and Invega. Weight gain is a side effect, so you can imagine how some people might choose not to take their medications because of the weight gain. Another side effect is that type 2 diabetes can result from taking these medications. Dose-related extrapyramidal symptoms, especially with Risperdal, and you need to use these with caution in the cardiac patients. We'll talk more about the other drugs, the SSRIs, which are antidepressants, and then our tricyclics, antidepressants, MAOIs, and we will get into the rest of these a little bit later. We've talked about some of them already during the anxiety lecture, so just keep all of these drugs in mind for this next test and for your boards. Social skills training. This can be helpful to give people social skills where they don't come naturally for them. That can help them with their daily lives. ECT, electroconvulsive treatment or therapy, in severe cases is used. It's only used when other treatment options have been exhausted and they've failed. And then psychotherapy is another option, and a lot of these are used concurrently with each other, but psychotherapy can be individual, group, or family therapy, or it can be a combination of the above. Nursing care, if our client has disturbed sensory perception, there's a care plan on page 1369. You need to be familiar with that. We want to develop trust. If you are on a psych unit or dealing with psych patients, many times, again, paranoia is at a height as well as fear. So these people, you don't just walk up to them and touch them. You are careful. You ask them, I need to do a physical assessment on you. May I listen to your heart? May I touch you to check, your lung sounds? If this psych patient is known to be violent in the past, you want to make sure that you are between them and the door. You don't want them to be between you and the door. And you may want to take backup help in there with you. If you actually do work on a psych unit, like the one in Lumberton, which is an acute care psych unit, and there's some in Wilmington and other places, but you will go through special training in how to deal with violence and how to deal with escalating clients and how to help them de-escalate without it turning violent. You want to allow them to verbalize their thoughts. Maintain consistent staff assignments can be important because once they have gained trust, it's probably not good to put somebody new in there every day to where they have to gain trust over and over and over again. Never whisper in front of a patient. If you've got someone who's paranoid in the least bit and you're whispering, they automatically are going to believe you're talking about them. So try not to do that. Try to avoid placing them in embarrassing situations. Do not reinforce their hallucinations or delusions. You can use distraction instead. And we want to provide a calm milieu. And a milieu is kind of like the atmosphere in the area. You want it to be calm, and if someone is acting out or escalating, it's best to remove them from the area or remove the others from around that person so that they don't also become excited and agitated. Disturbed sensory perception. is a nursing diagnosis that we use. Provide written instructions, monitor medication compliance, keep communication simple, use touch cautiously. There are times when you do not do a full head to toe on a client and you have to assess them from the side or even from the door. So, you know, safety is definitely important. I need to cover dementia before getting into Alzheimer's disease. So we'll go to slide 18 and then return here after we go over dementia and delirium. So let's move to slide 18. Okay, this is slide 18, dementia. Dementia is significantly impaired intellectual functioning, impaired normal activities and relationships, impaired problem solving and emotional control. There are personality changes and maybe behavioral problems. Realize that the term dementia is a symptom, not an actual disease. Symptoms included in dementia are significantly, like I said, impaired intellectual functioning. There's also mild cognitive impairment, which doesn't mean they have dementia. They're able to continue with their day-to-day functioning, although they are more likely to develop Alzheimer's. The etiology with dementia, there are many causes. Huntington's disease, also known as Huntington's chorea, is an inherited disorder that results in death of brain cells. The earliest symptoms are often subtle problems with mood or mental abilities. A general lack of coordination and an unsteady gait often follow. Parkinson's, Alzheimer's, multiple mini-strokes, chronic alcoholism, and medications. If we look at box 48.2 on page 1155, it talks about the medications. All these can be causes for dementia. If you look at the box, page 1155, some medications that can cause confusion, anticholinergics like atropine and antihistamines, analgesics like Demerol and morphine, cimetidine, which is Tagamet, central nervous system depressants like sleeping pills, tranquilizers, alcohol, steroids such as cortisone and prednisone, and then there is a website that you can go to. In general, it is thought that reduced blood flow to the brain and structural changes are the causes of dementia. Okay, lower risk. The higher education, the higher socioeconomic status, and those that engage in stimulated intellectual and leisure activities are less likely to have dementia. Signs and symptoms. Recent memory are affected first. Remote memory is affected later. They may forget how to perform simple tasks. They may do something that we call wandering. They're going around, walking around with really no place to go or don't know where they're going. Aphasia with an S has to do with speech, and that can be all or different forms of aphasia, behavioral problems, and then eventually total dependence on others. With the diagnosis, they go through neuropsychological testing, testing for depression. Certainly they're going to look at their medications to see if any medications might be the cause. They would probably have an MRI, CT, possibly a PET scan, looking for underlying causes of the dementia. Therapeutic interventions, medications that delay progression, medications that delay progression would be our cholinesterase inhibitors and our NMDA antagonists, and those are things like Aricept and Namenda. Certainly, end-of-life decision-making might need to be considered at the later stages or as the dementia progresses. These videos, I'm pretty sure we cannot watch them, so we will show them in class if you're unable to watch them at home. And you probably will have to come off of this screen and go to your PowerPoint if you're going to try to watch them at home. Nursing diagnosis for dementia, risk for injury, imbalanced nutrition, chronic confusion, and caregiver role strain. All of these are certainly things that may occur. Okay, let's look at delirium. This is a temporary mental disturbance. It is unlike dementia. It is rapid or gradual at its onset and is considered to be a medical emergency and should be diagnosed and treated promptly. It's characterized by disorganized thinking and difficulty staying focused. It's most common in older adults who are experiencing illness. Those most at risk are the severely ill, those with a history of hypertension, alcoholism, or any pre-existing dementia. Sometimes it's caused by medications, and again, we've got our box 48-2 on page 1155. Also can be caused by stressors on the body, pain, oxygen deficiency, urinary catheters, fluid and electrolyte imbalance, change in environment, or nutritional deficiencies. Having a family member present is often the best intervention. Also, continuity of nursing personnel can help because of that trust issue. I talked to you about my grandmother, I think, at one time, but everyone may not know the story. She had some, what we consider sundowners at the hospital when she was admitted, and they had to actually restrain her through the night. But in her mind, and she told me this after she was home, and her mind had cleared, that she was dreaming, or in her mind, delusional, it was real, that she was in a home or a house that was locked. She could not get out, surrounded by trees in the forest, and the forest was on fire. So that is what she was dealing with throughout that time of confusion and delirium. So please have patience with your clients who are experiencing this. Know that they're not just trying to be hard to get along with. They're not just being combative for no reason, because in their mind they may be going through some pretty bad stuff. All right, there's a nursing care tip somewhere in your book. Okay, it's on page 1156. Make sure that you're reading that, and also the evidence-based practice. Make sure that you're reading and thinking about that. Both of those are on page 1156. Okay, now we're going to go back to slide 12, I believe. Slide 11, which is Alzheimer's disease. The pathophysiology, progressive and degenerative. That means it will not get better, it will not peak and stay at the same level. It is going to worsen as time goes on. You may hear it called dementia of the Alzheimer's type, and it is the most common type of dementia. It interferes with memory, the ability to think clearly and to learn, and eventually it interferes with the ability to function. Alzheimer's is more likely in women than men, and the incidence doubles for every 5 years a person lives beyond 65. You'll hear them talk about plaques that are found after someone dies when they do an autopsy, and those are plaques that indicate Alzheimer's in the brain. The etiology is unknown. It may be genetic. There are theories including viral or bacterial infections. There's a theory about it being autoimmune. Markers associated with Alzheimer's can be found on several chromosomes, particularly the one responsible for Down syndrome. So those with Downs over 40 usually develop Alzheimer's. Lifestyle factors like hypertension, hypercholesterolemia, and poorly controlled diabetes may also contribute. Alzheimer's disease causes neurofibrillary tangles instead of normal orderly arrangement. Patients also have a deficiency in the neurotransmitter acetylcholine. At first, they'll have short-term memory dysfunctions. Then, as the plaques spread to the temporal lobe, the memory impairment becomes more severe. Personality changes and incontinence inevitably occur as the frontal lobe is affected. Interestingly, the subcortical area of the brain is left relatively untouched. This part of the brain gives us our subconscious urge to survive. We need shelter, food, water, security, and reproduction. All of these are controlled in this part of the brain. They may feel hunger, but no longer know how to meet that need. If not tended to, they would starve and possibly dehydrate from not drinking. The younger the client with Alzheimer's, the quicker they progress. Signs and symptoms, stage 1, this is the early stage at 2 to 4 years. It's characterized by increasing forgetfulness. They attempt to cope. They may use lists and reminders. Their interest in day-to-day activities, acquaintances, and surroundings tend to diminish. If they still work outside the home or either inside the home, their performance will deteriorate. With stage 2, the middle stage, this is the longest in duration. It lasts 2 to 12 years. They have progressive cognitive deterioration, causing difficulty if they're asked to perform a task they no longer know how to do. They may become irritable. Depression is common. Cognitive function significantly decreases. Their normal sleep-wake cycles are disrupted, and they wander, especially at night. They easily become lost in familiar surroundings. Anxiety will become a problem. Personal hygiene will deteriorate, and some may say things they can't find are stolen, or they may hoard food or money. With stage 3, progression to complete dependency, they're completely dependent on others. They cannot converse or control their bowel or bladder function. If they're mobile, they need constant supervision. As you can imagine, the lack of recognition of family and friends can be devastating. Death usually comes from complications of immobility, like pneumonia, a DVT, or pressure injuries. The healthier the person is, the longer they will live despite these things. A very important thing to think about is the difficult decisions about feeding tubes and respiratory intubation. The feeding tubes can prolong their life. This is a very emotional decision and is very difficult for families to face. So that's something you very well may have to deal with in your practice with older adults. On page 1167, the table compares Alzheimer's and Parkinson's. 1167. Make sure that you are familiar with the differences in these two. Huntington's is not as common, so but just read over this and make sure you're familiar. I do want to say that table 48.13 on page 1167, there is a error in the table. If you look under Parkinson's and involuntary movements, they are present. Parkinson's has involuntary movements. But if you go over to Alzheimer's, the involuntary movements are absent. So please fix that in your book. With diagnosis, the only sure method of determining Alzheimer's is through an autopsy. So that tells you that things are, it's difficult to diagnose, especially early on. It's diagnosed based on clinical exam until the person passes. They look at history, they rule out other symptoms and causes or other causes of the symptoms. An MRI can reveal tangles and plaques, and a PET scan can also potentially help with diagnosis. Therapeutic interventions, realize there is no cure for Alzheimer's. You want to minimize the effects of the disease and maintain their independence as long as possible. Page 1156, that's your care plan and interventions. Acetylcholinesterase drugs like Aricept and Exelon are thought to break down the neurotransmitter acetylcholine, and they help in mild to moderate Alzheimer's patients. Using these drugs can delay the need for around-the-clock care, usually in a nursing care facility, which is huge to patients and family. If they can keep them home for a while, quality of life is improved, or at least is not going down. And the financial burden also that goes along with long-term care is important to the family and to the patient. Another type of drug, NMDA antagonist, can prevent the overexcitation of NMDA, and Namenda is this drug. It is the only drug available in this class. It can be given at any stage, and it can also prevent decline. Antidepressants, antipsychotics, and anti-anxiety drugs help with symptoms and behavioral disturbance, but these only help with symptoms. Again, there is no cure. These drugs are also found in that drug table that we have been referencing. Nursing diagnosis, risk for injury will always be the case, imbalanced nutrition, chronic confusion, and again, caregiver role strain. Okay, I'm going to go on down to your review questions. The first one, a patient with late-stage 2 Alzheimer's dementia is throwing half-eaten food from the meal tray onto the floor. Which response by the nurse is best? And the answer to this one is number 4, to offer food alternatives and stay with the patient during mealtime. Second question, positive symptoms of schizophrenia include which of the following? Delusions and apathy. This was a select all that apply. And that would be the end of Module 16. Again, we will debrief on these modules when we're able to see each other again at school, but please make sure you're watching them, listening to them, and reading. Thank you.